Hello and welcome to Dr. Walaeddin Ahmed review series. Today we are talking about acute conjunctivitis. This video is for educational and informational purposes only and does not constitute professional medical advice, diagnosis, or treatment. Always consult with your doctor or qualified healthcare provider with any questions you may have. Conjunctivitis is a common eye condition. A useful way to recognize it is this. If the eye is irritated, red, and has discharge, either watery or purulent, then conjunctivitis is likely. Conjunctivitis may be caused by infection, which can be viral or bacterial, or it may be allergic. In clinical practice, it can be difficult to differentiate viral conjunctivitis from bacterial conjunctivitis based on clinical features alone. In adults, around 80% of cases are viral. In children, however, the majority of cases are bacterial. The good news is that conjunctivitis is usually self-limiting, and it often settles within 5 to 7 days. It is usually unilateral at first, although it often spreads to the other eye. In bacterial conjunctivitis, the discharge is often yellow-white and mucopurulent. Pruritus or itching is usually not present. There should be no loss of vision and no blurring of vision, apart from blurring that clears with blinking. Any blurring of vision that does not clear with blinking, or any corneal opacification, should prompt urgent referral to an ophthalmologist. Now let us consider allergic conjunctivitis. Allergic conjunctivitis is typically associated with itching. It is more common during the summer months. The discharge is watery. There is usually no morning glued eye, and there is no photophobia. Children with conjunctivitis do not need to stay away from school or childcare if they are otherwise well. However, the school or childcare provider should be informed. A topical antibiotic may be used if needed. One approach is to consider a delayed prescription for 3 days, along with eye self-care advice. For self-care, advise the patient to wash their hands. They should boil water and let it cool down completely. Then they can wet a clean cotton wool pad and gently wipe the eye from the inner corner to the outer corner once. A new cotton wool pad should be used for the other eye if needed. They can also hold a clean, cold flannel over the eyes for a few minutes to cool them down. Now, contact lens use is important. Patients should not wear contact lenses for 2 weeks or until the symptoms have resolved. They should consult the optometrist who dispensed the contact lenses regarding cleaning of reusable, non-disposable lenses. Fusidic acid has minimal gram-negative activity. This matters because, in contact lens wearers, infection may be gram-negative. Patients should seek medical advice if there is no improvement after 2 days of treatment, or if new symptoms occur, such as eye pain, photophobia, or affected vision. Chloramphenicol is not recommended in pregnancy or breastfeeding. Next, think about when to swab, refer, or seek specialist advice. Swabbing should be considered in chronic infection, recurrent infection, or infection that is not responding to treatment. Adenovirus conjunctivitis can last for 2 to 3 weeks. Refer patients with severe pain, suspected gonorrhea or chlamydia infection, or chronic infection lasting more than 1 month. Severe cases may require systemic treatment, so these patients should be referred. Hyperacute conjunctivitis is characterized by the onset of severe purulent discharge within 12 to 24 hours. In this situation, consider Neisseria gonorrhoea. Risk groups include neonates in the first week of life and sexually active people. Serious complications can include uveitis, keratitis, and corneal perforation. Conjunctivitis in the first month of life may indicate chlamydia trachomatis infection. These patients should be referred. Adult chlamydia trachomatis conjunctivitis may present as a chronic conjunctivitis lasting longer than 2 weeks. It causes low-grade irritation and mucus discharge in a sexually active person. Pre-auricular lymphadenopathy may also be present. Suspected herpes simplex or herpes zoster eye disease is another important concern. Reduced visual acuity, photophobia, contact lens use, and moderate to severe eye pain may indicate sight-threatening disease. These features warrant an urgent ophthalmology opinion. Remember that contact lens wearers are at increased risk of corneal infection. Now let us go through the acute bacterial conjunctivitis treatment table. The first choice treatment is chloramphenicol 0.5% eye drops. The dose is 1 or 2 drops 4 times daily, continued until 48 hours after symptom resolution, with a maximum duration of 7 days. Chloramphenicol should be avoided in pregnancy or breastfeeding and used with caution in children under 2 years. Chloramphenicol 1% eye ointment is unlicensed. It is used 3 to 4 times daily. The ointment may be preferred in individuals who find the frequency of drops difficult to comply with. It is for adults and children over 2 years only. Patients should be warned that the presence of ointment may blur the vision. Second choice options include azithromycin 15 mg per gram eye drops. The dose is 1 drop twice daily for 3 days only, even if symptoms are still present. Another second choice option is fusidic acid, 1% viscous eye drops, or suspension. The dose is 1 drop twice daily, continued until 48 hours after symptom resolution, with a maximum duration of 7 days. Fusidic acid has minimal gram-negative activity, so it should be avoided in contact lens wearers. Finally, when applying eye drops, the dropper should not touch the eye. This helps reduce the risk of spreading or prolonging the infection. Patients should wash or disinfect their hands after application. Key takeaway ending: conjunctivitis is usually self-limiting, but it is important to recognize red flags. Blurred vision that does not clear with blinking, corneal opacity, severe pain, photophobia, contact lens use, suspected gonorrhea or chlamydia, and neonatal conjunctivitis all require careful referral or specialist input.